coming. My name is Sarah Lynn. I work for Millennium Collaborative Care. It's a company that was awarded a state grant to reform different aspects of healthcare, make them more efficient and more patient and user friendly. So we're going to talk today about the INTERACTT program, and for some people we're going to talk just about that stop and watch tool, and then for the nurses you get to learn about a lot of different tools. So be prepared to be wowed. We'll talk a little bit about hospitalizations. I'm sure it's not going to be any new news to anyone. We all know hospitalizations are, going to a hospital is sometimes a necessary evil, especially for our patients, our frail elders who have 2, 3, 4, 7 chronic conditions going on. They may be, really a requirement in order to diagnose and treat a patient that has an acute illness. But in many situations, if some of their chronic diseases, if the exacerbation was caught sooner, this hospitalization could have been avoided. So that's where we're trying to pinpoint, is those opportunities that a hospitalization is really preventable and it's avoidable, and trying to make sure that we are indeed avoiding it. We all know we'll have our patients come back from the hospital sometimes and they look 10 times worse than when they went, and you wonder, what happened. Patients lie up in a bed for a couple weeks, they get they have decreased mobility, they could have falls because they're delirious if they have dementia and they're taken out of their home setting or their normal environment. A lot of times catheter placement is, a routine thing that's done in a hospital, and that could lead to a UTI or other hospital-acquired infections. So really, it's an issue sending a patient to a hospital. It's not always the best thing for them. Right now, the current rates are anywhere from 15 to 25% of patients who come to a skilled nursing facility are readmitted into a hospital within 30 days. Now, I will say that I just found out yesterday that Riote's rate is 6%. So congratulations, that is a true testament to you guys that you're really doing everything that you can to recognize symptoms early and keeping patients in this setting. So for the rest of the country, that is not Riote, a lot of the conditions, 5 out of 6 of them, are congestive heart failure, COPD, UTI, pneumonia, and dehydration. So out of all of those conditions, do you feel like any of those hospitalizations could have been avoided or prevented? Probably. Usually someone doesn't become dehydrated within 1 day. They don't have a UTI that's severe enough to require hospitalization within 1 day. Usually it's a 3, 5, 7, 10-day incubation period where it's slowly getting worse, and those are all opportunities for us to pick up on those subtle little changes in behavior or personality or physical ability that are indicative of a change in status. So what do you guys have to do with all that? Direct care staff, you're the first line of defense for our patients. The thorough care that you give, you're keeping patients clean, you're following care plans, making sure they're getting the right consistency diet, they're getting the right transfers, they're getting the right assistance. That's all great at keeping our patients safe. Nursing, you're giving the right medication at the right times with the right medication. All of those things are going to help keep their chronic conditions, those symptoms at bay, and that's really going to keep our patients healthy. In addition to being the first line of defense, you're also the first line of offense. So you know everything about these patients. You see them more often than their family does, much more often than the doctor does. You see them at their most vulnerable states. They're usually not trying to put on a show for you. You're seeing their true person. So you really have the ability to know when someone, if they're having a change in personality, or their behaviors are a little off, or their physical ability seems a little different than yesterday. Because that's what we're trying to pick up on, those small little changes that over time build up to one huge change and a true change in condition and a need for hospitalization. So we're trying to pick up on these things when they're small, before the big dominoes start falling, if you will. So noticing the subtle changes is one thing. It's documenting it and making sure that the people who need to know that something's going on knows, indeed. I'm an occupational therapist, and there would never be a worse time than when I came in on a Monday and I found out that my favorite patient went to the hospital, and I thought to myself, I definitely saw that coming. Did I, Wednesday, did I track down the nurse? I know she was on lunch. Did I ever get a hold of her? Thursday, I noticed that she was even more tired, and I couldn't find the nurse again, or it was my fault, I was too busy and I forgot about it. That's the worst feeling, that you could see something coming and steps were never taken to remedy it before the patient ended up going out to the hospital. So, we're really trying to educate any of the staff that comes in contact with the patient to, be aware of the little changes and the little things that can happen, and making sure they're letting the nurses know, so that it's not all of a sudden the patient's really ill and is being transported by an ambulance to the hospital. And that's where the INTERACTT program comes in. So what it is, it's a quality improvement program. It's evidence-based. It's been implemented around the country, and for facilities that have implemented it well, it's been shown to have up to a 25% decrease in hospital readmissions. So it's a quarter less patients going out to the hospital every month, so that's great. I do want to say, the goal of INTERACTT is not to prevent all hospital transfers. It's to improve care. So we're not going to be barricading the doors and nailing them shut and never letting you call 911 again. That's not the case, because the hospital definitely is the right place for people sometimes. It's really those hospitalizations that, we really could prevent, we really could avoid if we just would have paid closer attention. And really we're trying to get to the point where, I don't want to get to the point where we're, should they go to the hospital or should they not? Like, this should be happening way before, when, I noticed this small little change and I'm going to see what I can do to stop it there before it goes any further. So INTERACTT strategies. So like I said, INTERACTT, it prevents conditions from becoming severe enough to require a trip to the hospital through early identification and evaluation of changes, and then managing those conditions without transfer whenever it's feasible and safe. And then improving communication and documentation, not only within your facility and the staff here, but between the skilled nursing facilities and the hospital as well. So, part of the program I'm running is talking with the hospital staff, talking with the ED staff, making sure that, the communication's happening on both ends. Because we know it's not only breaking down here, it's not only breaking down there. It's a problem that's occurring across the sites. Good communication is key. We all know that it prevents mistakes. Better care is provided, higher job satisfaction for you guys. And we all know if we have safe and happy and healthy residents, we have happy and healthy staff. Whenever our residents are sick and miserable, and usually we're sick and miserable too. So this benefits all of us. Why don't we cruise forward to the Stop and Watch tool? We'll do that one and then we'll come back. So the Stop and Watch tool,
One more.
for the people in the room that are not nurses, this is kind of going to be your voice and your chance to really be an advocate for your patients. It might not be intentional sometimes that you forget to tell a nurse that you notice something. We all are doing a million things at any given time and things slip our minds. So this is a good tool to use. In order, if you notice a little change in someone, all you have to do is circle whatever, is the correct category determined by this Stop and Watch acronym, and then hand it over to your nurse. So, Stop and Watch, like I said, it stands for all these different little subtle condition changes that you might notice. So, the residents talking or communicating less, they have new or worsening pain, a weight change, they're more agitated or nervous than they usually are. So these are all not only physical symptoms, but behavioral and, personality symptoms too that might be indicative of some sort of brewing infection or exacerbation that's along the way. So all you have to do is put the resident name on here, circle the correct condition, put your name, what the time and the date is, and then hand it over to your nurse. So this tool can be used really anytime in your shift. It can be used whenever you feel like something has changed in the resident, but you want to make sure that you're really completing whatever care you're doing, and you're leaving the resident in a safe and respectable manner. So you never want to be halfway through a shower and you're noticing that the patient is acting funny or needs more help and then leaving them in the shower. You should always be finishing what you're doing, making sure that they have their meals if you are passing trays, or they're completely clothed when you're leaving them before you start filling out a form and talking to a nurse. That is, of course, unless there really is a severe something going on where someone is coding or severely short of breath, something like that, we would need emergency assistance. And I just put here too, this tool is to be used in conjunction with a conversation with the nurse. So, no one should ever be taking these forms and just chucking them up on the carts and running away. So nurses, you should be having a small little conversation with whoever's giving you this form. Doesn't have to be 10 minutes, doesn't have to be 5 minutes, just a couple sentences. What do you mean they seem different? What do you mean they're nervous? What was going on? Because maybe right then and there you'll discover, maybe the nurse knows that, their son just died or something like that, and that's why they're despondent or weepy. that the aide didn't know. So having that little conversation is important so that we can kind of figure out what the causal factors might be. I think, yes, okay, so for example, so would you fill out a stop and watch when Mary chose to wear her uncomfortable red heels instead of her usual sneakers to lunch? Probably not. That doesn't really seem to influence her health very much. Ethel's urine was darker than usual and had a strong smell. For sure. This is something you should always be notifying your nurse about. Chatty Cathy was very quiet and despondent during her favorite activity today. Chatty Cathy is indeed usually very chatty. You know, you probably want to, it's a personality change, so you want to definitely be documenting that. Clarence tried hitting you while you were putting his clothing protector on. Maybe. Did you sneak up from behind him and do the, the quick attack there and startle him? That would probably be a reason why he would try and reach out and hit you. If you have a patient who always at change of shift is trying to get up and go home with the rest of everyone, that's probably not something you would document as a change if they're continually trying to get up. Whereas if you have another patient who you gotta get like the jaws of life to get them out of their wheelchair, but all of a sudden they're antsy and trying to get up all the time, maybe they have a hemorrhoid, maybe they have a UTI or something that's becoming painful for them to sit. So that would be a change in condition and something that we do want to note. I think for the people who are not nurses, this is the form that we were talking about, and right now it's laminated, and it's on the front of the bathroom door in the patient's room, and there's a dry erase marker attached to it. So it makes it really easy. Just fill it out, go bring it to your nurse, give a couple sentences about what you think is going on, and that's going to trigger a nurse to do an assessment on the patient.
Question.
Mm-hmm.
Reception. Is that form also online that we can fill out and print rather than go to the patient's room?
Yes, that's exactly what I was going to say. So we've learned from other people who are not in the CNA or nursing field, and they might not be in the rooms, activities, therapy, reception, dietary. We're going to make copies of the form, and then it should be available at any of those sites in a folder or something that you can easily just grab one and fill it out. So you shouldn't be needing to tromp all the way down to their room and then all the way back to the nurse. So we want to make it as accessible and as easy for you so that this isn't putting you out in any way, because you're not going to do it then if it's very it takes a lot of time and energy for you. So this should be a couple-minute process, if that. So, and it really will make a difference in your patient's health and well-being. So we appreciate it, your engagement and your advocacy for your patients there. All right. So I think if you're not a nurse, you could probably be dismissed at this time. Thank you so much for coming.
Thank you.
Streets by.
Thank you.
Thank you.
Thank you so much for coming. And Deb, we could probably go back then to those transfer forms. So a couple of things we're going to talk about. Now, I know Denise and Mary have big plans for some things, no plans for other things. So they're really going to be the powers that decide what sort of tools we're going to implement and what ones we're not going to. Now, eventually, when and if Briody goes to an electronic medical record, a lot of the EMRs now have all these tools embedded in the software. So it's not like you're going to be doing redundant paperwork. Some of these notes or some of these forms would replace forms that you may currently be filling out now, or narrative notes that you might be doing now. So
We're gonna check with SigmaCare, because we're already on board with SigmaCare. We just don't know if they have the Interact tools.
Are projected to have a module available sometime in the future.
Okay.
So hopefully that is the case. So the first form here is a nursing home to hospital transfer form. So I know that you guys already fill out some sort of form. A lot of it is probably similar information to what is on here. So you'll probably just, you could take a look at this, think if this might be valuable, or if it's really just something that it's a little bit too much to do, or it's just redundant, it's the same exact thing that you're doing now. The front usually is the necessary information, really what needs to be communicated to the ER or the hospital. The back is information that's nice to know, but if you're short on time, you could fill this out later and fax it or something like that. So I'll send it, try to pass it around. The next form is an acute care transfer document checklist. So this is really great.
This one?
Yep, perfect. So this one, because I know when you're sending your patients out to the hospital and the family's there and you're crying and your patient's upset, and then you had 4 people call in and it's just crazy madness, and you might forget to send something to the hospital. So a lot of facilities opt to put this on, print it right on an envelope, and then whatever envelope you're sending to the ER, to the hospital, you know, this is the envelope. So you can check off that you have everything that you need in that envelope, so that the hospital isn't calling and waiting for information for you, or they're not redoing all the medications, and then when they come back it's going to be a huge nightmare. So this really is going to help, you know, talk about that communication. We're trying to prevent any of that communication breakdown by giving as much information as we can to the acute care side. So I can pass around even though you
Now
can't.
that bottom part, we've been told not to be sending that stuff.
Yeah, and you don't, I mean, you have to go by what your facility recommendations
Right.
are.
Okay.
So if you don't need to be sending those things, that's something that we have to talk to, you know, the medical director and Mary and Denise and see, you know, what this facility wants to send. So these forms can also be tailored to this facility. So if they want to take that whole part out, they can do that. You just got to take off this little INTERACTT logo then. Okay. The next form, this is a pie in the sky form that I think is funny because it's a hospital to post-acute care transfer form. So there's no way that I think the hospital is going to be filling this out by hand. I know they're just going to continue sending their discharge or transfer summaries. But what I think this is awesome for is for those nurses who are taking report from the hospital. Because I know you have a window of opportunity to talk with the nurse over at the hospital. If you forget to ask something and you hang up, you're probably never getting a hold of that same person again. So this form is great because it has everything listed out, especially for our new nurses or for when it's just crazy and you're trying to talk real quick. You know, it has everything laid out, so it's kind of a prompt to say, oh yeah, what was their blood pressure? Oh yeah, what was their transfer? You know, it will kind of be a good reminder for taking a report on a patient that's coming over to you from the hospital. Okay. So I think Mary yesterday had said that she liked this worksheet. Some people might love it, some people might hate it. It's the medication reconciliation worksheet. So I know MedRex is probably one of the most time-consuming, you know, really just nitpicky things that you need to do as a nurse. So this is really a sheet that has, you know, hospital-recommended medications needing clarification. So how often am I giving this? What dose am I giving this? What, you know, they're already on a similar medication. Why are they on this one too? So when you're looking through all the medications, you can jot all these notes down. And when you're on the phone with the doctor or when you're faxing stuff over, you can just fax this sheet and say, this is the complete list of, you know, issues that we had with the medications. Can you please, you know, tackle each of these issues and try and remedy these? So it just has everything all in one spot so that if you're on the phone, you don't forget to talk about something, or if you're faxing information over, it's nice and neat so there's no questions, you know, what you're trying to say or what orders you're trying to get clarified. And a lot of these forms, they may not be part of the medical record. You can use these as like a scratch pad and toss them, you know, in the confidential bin when you're done if the patient's name or, you know, health information is on there. So you don't have to be afraid of using these and making them perfect because they're going to go in the medical record. A lot of times these things won't. They're just really tools for you in order to make your job easier. The S-bar. How many people know the S-bar? Okay, so I think this is kind of the new SOAP note, if you will. I know a lot of nursing programs now are teaching this method of narrative note. So SBAR stands for Situation, Background, Appearance or Assessment, and Response. So, you know, this is a good layout of that acronym that INTERACTT has developed in this form here. So we're going to go through a little case study. Oh, you can, sorry. I never know what I'm doing with PowerPoint. You can just click through all of those. Sorry, it's all like different little
Trying to.
tabs. Oh, okay. Well, this is just going through the purpose of the S-bar. So it really makes, you know, a consistent language. You know, it gives standardized criteria. You know, everything is laid out the same so that every nurse is documenting the same. So it's easy to find information. You're not reading through a paragraph of narrative note in scribbled handwriting that you can't read. So it makes it easier for, you know, people to reference medical information. So, a situation. You have a 79-year-old resident with a rash covering her trunk, arms, and legs, a few blisters, and a temperature. You know, this patient feels uncomfortable and you obviously are trying to remedy the situation. So would you guys, you know, would you call the doctor at this point? Like, what would the next step be? Trying to figure out what's going on.
Go look and see what medication she might be on.
So looking at the medications.
Something new.
Yep, making sure you're looking at their history, looking at what they've done the last couple of days. You know, having all of that information is huge. So if you were to just bring that information, which we know some nurses, some facilities will try and call the doctor with that little information, you can just keep clicking, Deb. These are all, yeah. You know, it's going to be really difficult for the doctor, for the nurse practitioner to make,
Yeah.
to make a, you know, a recommendation from that limited amount of information. And, you know, you really want to, you know, these areas, this rash started on this date. Since it started, it's gotten worse, better, stayed the same. You know, it looked like it was getting worse when we did this. It looked like it was getting better when we did this. So having this sort of information is key for a doctor or a mid-level to be able to make an informed decision. You can go to that next one. So also, you know, what happens is, you know, we'll call a doctor and all we have is the temperature. Well, you know, you probably should be going down there and, you know, if that was the temperature that the aide got on change of shift, you know, if you're calling the doctor, you really should be the one that's going and seeing the patient, laying hands on the patient, doing an assessment yourself, you know, before you're calling and trying to communicate that information to someone else. So what if you knew that they just started a recent course of amoxicillin after you did the med review, or the daughter visited and she had shingles, or went to a cookout and sat near poison ivy, or the roommate had scabies. So, you know, you want to make sure that you're getting, you want to make sure that you're getting all of that information, because that's really going to dictate, you know, where the physician, you know, tends to focus their treatment on. The best physical exam is useless without the history, so really need to do both. We need to actually be doing a physical exam, so getting the heart rate, getting the blood pressure. You know, the doctor is not going to be really happy if you're calling them and you don't have that information ready for them. That's actually, so right here, before calling the physician, NP, PA, you want to make sure that you're evaluating the resident, so completing those aspects of the SBAR that are relevant, checking the vital signs yourself, reviewing the records, so having their chart in front of you, knowing their past medical history, knowing their most recent course of hospitalization or medications, and then having all of that background information too is huge. I know when I've talked with doctors and mid-levels, and even with nurses too, there seems to be this bad relationship in a lot of relationships that, you know, the nurses are weary or don't want to call the doctor because the doctor's nasty and they hang up on me, or they're rude, and then the doctors don't want to hear from the nurses because the nurses, they never have enough information. I'm on the phone with them for 15 minutes and they're flipping through the chart and they're having people run down and get vitals, and that's when everyone just throws up their hands and says, just admit them to the hospital. Because I don't have enough information, I don't have time to deal with this. And that's really, if that's the reason why our patients are going to the hospital, then that's really unfortunate, because none of that has to do with their medical situation. So a lot of times, you know, this communication breakdown is really the cause of these hospitalizations, and our patients are suffering because of that. So we really want to try and making sure that we have all of our ducks in a row, so that, you know, when we have a conversation with the doctor, it's a good one, and then in the future the doctor will know, oh, Briody's calling me, I know they always have their stuff together, so I'm going to answer it and be pleasant, and, you know, it's going to be a good conversation that will last 5 minutes and we'll have an effective outcome. So, you know, that's really key for this relationship to work. So we can just cruise through these. I mean, this is just the SBAR, the different forms. I know it looks like a lot, but really these are all different areas. So mental status change, functional status evaluation, behavioral. So really you're only going to be filling out the parts that are relevant to whatever, you know, diagnosis or condition the patient's experiencing. And a lot of times, I mean, a lot of these are just check boxes. So instead of sitting there and writing a paragraph narrative note, this will probably be a lot easier for you, especially once you learn where everything is, because it's just a quick check, check, check. If you go one more after that, one more. Another one. So the A here is the appearance. So this is your, you know, area to write a narrative something. And as you can see, it's not very long. So just write a couple sentences about what you see, what you observe. And again, I can't say enough, you should actually be seeing and observing this. You shouldn't be writing on here, aide states that, or change of shift nurse stated that. You know, you really want to be the one that saw whatever you're stating that you observed. And then this is a section for who you called, what doctor or healthcare professional. you know, what tests or what they want to do, and then any more notes that you might have at the bottom.
These forms are, I just want to add, these forms are also a really good reference to go back to when you do write your narrative note. Because, you know, sometimes with all of that going on, all the craziness, you forget, like, oh yeah, what was their vitals? What, you know, what was their appearance again? Like, what did I say? You know, I remember going back and being like, oh, I forgot what, you know, it was exactly. But if you have it all at that time written down, and then later on when you can go back to it once things calm down and you write your narrative, you know, if that's how you do it, then it's a good reference to look back at, I think.
Exactly. And this is good to take, you know, when you're doing that assessment, when you're going in the patient's room, taking this with you so you can just do it there while you're doing the assessment and you don't forget to check something. That's the most annoying. I don't know how the setup is here, but like getting all the way to the nurse's station and start logging on and starting, and then you forget, you know, you realize you forgot to do something, so you have to go back, re-talk to the family, you know, like disturb the resident. So just getting everything done at one time is great. So that's where you could use this as a scratch pad or whatever you want. It doesn't necessarily, depending on how we want to implement it here, it doesn't necessarily need to be part of the medical record if that's not what you choose to do. Doesn't mean that you don't have to use it though, you could still use it.
These are presently kept in the reference book in each of the unit coordinators' offices in the pink reference book.
We can move on. So this is, I think, the best part and the most useful part about INTERACTT is the decision support tools. So these are the tools that, they're not forms that you need to fill out. These are tools for you to reference. So instead of leafing through, you know, your nurse's manual and trying to find stuff, or, you know, this kind of lays everything out for you on a flow chart, on a easy to read chart, so that you're not wasting time and energy trying to find stuff and shuffling around. You can click it through, Deb. Okay, so the first one is these change in condition file cards, they're called. So after you do your assessment, you fill out the S-bar and you're wondering, should I call the doctor now? Should I wait and see what happens? You know, this takes some of the subjectivity out of it. So I kind of like to, you know, relate to this as I have a 10-month-old at home. So it's kind of like, would I call the pediatric hotline tonight at 11:30 at night, or would I wait until the office is open in the morning? So kind of that sort of thing. So that the doctor or the PA isn't getting unnecessary calls at 2, 3, 4 in the morning when it could have waited until the office was open. So what these are, I can pass these around. You can click through, Deb, to the next. So these are charts. Like I said, criteria for immediate notification or non-immediate notification. And you can click through one more time. And these are, you know, really, this is a laboratory test and diagnostic procedure. So, you know, any of these labs that are done, you know, if they're within these levels, you want to report them immediately. If they're within these levels, you can probably wait until the morning to give the report to the doctor. You can click through one more time. Then there's also by, you know, alphabetical signs and symptoms. So you can kind of see that, you know, different signs and symptoms, this is the laboratory test one, would warrant different responses. So, for example, if someone's having, let's see what's up there, abdominal tenderness, you'd want to immediately notify the doctor or the mid-level if it's associated with a fever, if they have continuous GI bleeding, or any other acute symptoms. You could probably wait to notify a doctor if it's, you know, persistent discomfort and it's not associated with any other acute symptoms. So if it's just a little discomfort, it's probably nothing severe, but if it's associated with any of these things, you would definitely want to notify the doctor. So you can see here how there's this little subscript for some of these. There's a 1 here, some of the ones you might be looking at have a 2 or 3. If you go down here, it says, see INTERACTT GI Symptoms Care Path. So we're going to talk about the care paths next. Good, keep going. So the care paths, there's 10 different ones. Acute mental status change, change of behavior, dehydration, fall, fever, GI symptoms, symptoms of shortness of breath, CHF, lower respiratory illness, or UTI. So you can click one more, Deb. I think these are pretty cool because, you know, this really gives you, this is really all this is good medical practice. It's not groundbreaking science. It's not, you know, anything crazy that you've never heard before. But it gives you these tools that you can look at them real quick. You can, when you're calling the doctor, you can have something to reference, And you can even suggest, you know, maybe what you should do if the doctor or the mid-level, or, you know, sometimes we have those NPs that just want to send everyone to the hospital. You can, you know, have right in front of you, well, why don't we do this instead? Or why don't we try and check this instead before we